Hi, thank you for joining us for our second lecture in our second session of our point of care ultrasound series. And today we're going to look at lung and pleural ultrasound in practice. So hopefully this will become an area that is going to be helpful for a lot of our physicians and practitioners out in the emergency room or even in the acute care setting. So today's objectives, we're going to talk about how to describe the process of transducer selection and the processes to optimize lung and sonographic imaging of the lungs in a patient. We're going to apply standard lung scanning orientation and technique practices to produce optimal lung imaging, define the anatomy and artifacts on lung imaging, and demonstrate a complete lung scan protocol. Lung imaging with sonography. So what is it? So as a sonographer, when I first heard about lung imaging, I was like, that's not possible. Sonographers hate air. Air just disrupts our beam, creates dirty shadows. There's no way this can be real. And so I was a hard sell, but after looking at this and practicing with this, it really is a great opportunity to evaluate the lung, but not in the way that we generally evaluate things with sonography. So usually we use ultrasound to actually look at a particular organ and evaluate its echo texture and different things about the organ itself. Well, when it comes to lung, because it's filled with air, air just scatters our ultrasound beam. But how it's useful to us is that we can actually evaluate that scattering pattern or the artifacts it produces to determine if that lung is truly filled with air or not. So 90% of respiratory distress and failure cases are going to involve the pleura. So another opportunity for ultrasound in scanning the lung is that the pleura the pleura is external to the air, and so it is actually something that we can detect on ultrasound. So we can look for pleural linings and see if that pleura is fully extended to the thorax, making sure that there's no pneumothorax present. We can also then, like I said, use those artifactual evaluations to evaluate the lung, and a lung that is full of air is going to have what we call A-line artifacts, which will help us determine that it is full of air. When we're looking at that pleural lining and at the air-filled lung, we're getting the good real-time information. And you as practitioners can utilize that to treat your patient quickly without exposing them to a lot of radiation in CT or without the time or discomfort of having to transport that patient for some of those complicated studies. Some clinical studies have even demonstrated that lung ultrasound can have nearly the same accuracy as CT for acute respiratory pathology. Now, the overall view you're getting is not going to be as clear or as much detail, but with ultrasound as it would with CT, but you're going to still get the same answers that you're looking for. So what are we looking at? Like I mentioned, we're going to be evaluating where the pleura and the thorax interface. And we're going to make sure that those the visceral and the parietal pleura are intact and that the parietal pleura is then sliding. Now, the pleura is so thin, as we'll talk about in a minute, that it would be difficult to see one layer of pleura opposed to another layer of pleura. So what we really do, we can recognize that pleura, and if we see the sliding there, then we know that that lung is aerated and that the pleura are intact. We're also able to, like I said, assess that pleura for appropriate motion associated with breathing. So lack of pleural motion would indicate that there's a pneumothorax and that parietal pleura is collapsed and therefore not sliding against the the visceral pleura is collapsed, not sliding against the parietal pleura. Another thing could be is if you had some sort of paralysis of the lung or something like that, then you would lose that motion that we're expecting to see. Another thing that we can see here is actually not artifactual as well, but it would be a pleural effusion. So pleural effusions are fluid, or blood, and either way they're going to appear as an anechoic filling of fluid, and because fluid is well visualized under ultrasound, we can just simply look in that pleural cavity and see if there is fluid there, and then evaluate from that point. We can also recognize pulmonary consolidations by changes in the artifact pattern. So as I said, a fully aerated lung is going to demonstrate those A-line artifacts that we're going to look at here in a bit, because they can't they can't propagate the sound through the lung because it's filled with air, and therefore it's not going to contribute to producing an image, but rather provides artifact. If there's consolidation in that lung, it fills up that lung tissue so significantly, displacing that air, that now it acts as a propagation material for the sound, and we actually get an image back. So kind of opposite of what we would generally think in sonography. In lung sonography, in the case of consolidations, the visualization of lung tissue actually means that there is a problem. So some of the pitfalls, however, with lung imaging is we know with anything with ultrasound, it's only as good as the sonographer. And then to take that one step further, the sonographer can sometimes only be as good as both their training and the equipment that they have. And we know as lung ultrasound is relatively new, and some of us like me were very skeptical. You know, the use of it out in the field has been somewhat limited. So getting everybody trained, making sure everybody's confident is going to really make these exams much more successful and probably more widespread in the near future. So that lack of education has really been a tremendous setback. Lack of experience, so maybe you've gotten the education and yet you just haven't had the equipment or the opportunity to implement the new practices. The more experience you have, the more things you've seen, obviously, the better you're going to get. And then finally, inadequate imaging devices. So they're selling a lot of the handheld imaging devices now, which can be really good for certain applications, but sometimes they're not the best resolution. And really, when we're looking at the pleural sliding, we really need a pretty decent resolution system. And so we can really be limited by the quality of our imaging devices. So if you're shopping for equipment, make sure that you're working with the manufacturer to make sure that they are capable of doing these lung studies to an adequate degree. One other thing with, like I mentioned slightly earlier, is that these can give you the answer, but they're not necessarily going to give you the same sort of detailed information that you're used to getting with a CT exam of the chest or even a chest x-ray. And so you have to keep that in mind with perspective, but the time it takes, the dose it saves, and the patient, you know, and just being able to provide that patient with immediate care can sometimes offset what you feel like you're losing by moving toward this type of exam or adding it as an option. So when we look at the anatomy of the lung on ultrasound, what we're going to see is the chest wall will be most superficial, so you're going to encounter that with your transducer first. So here would be the subcutaneous and adipose tissue. This is a thin patient, so we get right into the chest muscle wall. And then you see this interstitial or intercostal space here. And then your ribs are going to be bony, so they are going to attenuate a lot of beam, appear very anechoic with posterior shadowing. So these shadows just indicate that we are really not receiving any sound feedback from these areas because the ribs are attenuating all that sound, not allowing anything else to go through. So we want to see those shadows because that tells us that that's the space in between the rib and that this is going to be our pleural area. So at this point, at the bottom of this intercostal line here, you'll see an echogenic area that's going to represent the pleural line. And again, the pleura, the parietal and the visceral pleura are very, very thin, so thin that they are too thin. They are not thick enough to be picked up by ultrasound resolution. However, we can see them together as one echogenic line, and then if we see one moving or sliding in this general region, we're going to know that that is going to be the visceral pleura, because of course the parietal pleura is adhered to the wall. So watching for that sliding is going to be very important, especially when we're assessing for pneumothorax. So we have subcutaneous tissue, we have musculature, we've got our ribs with our intercostal space, and then we get into our pleural line. And then beyond our pleural line, what we should be seeing in a nice air-filled lung would be lung parenchyma, which we can't see if it has a lot of air in it, so it's going to look something like this. This is going to be the artifact produced when sound interacts with air. You can call this a reverberation or a ring down artifact, but what you see is these echogenic reflections at equal distance from each other. Now that indicates that that lung is filled with air, and if I see that echogenic line sliding here, I know that that pleura is, the visceral pleura is moving along that parietal pleural line. Now, if we broke down the lung even more, as you all are way more educated than me in this, we know that that lung will break down into ultimately alveoli, and those alveoli are going to be suspended by intralobar septa. Now, a note about the intralobar septa, they too are too small for us to appreciate on ultrasound. However, when we start seeing lung consolidations and things like that, you'll see those intralobar septa take on fluid, and then at that point you can start picking those up as consolidated areas where you might be able to get rid of some of this artifact, get transmission and propagation by the beam, and actually see that lung tissue. In that case, however, we know that that's an abnormality allowing us to do that in the lung because we should just see artifact. So as I talked about before, the aerated lungs, what we're really looking to see in the actual lung area is artifact, not tissue. And so the image you see here on our right is actually a normal lung tissue, and we see that if we were to find a sliding pleural tissue here, followed by what we call these A lines or artifactual lines that would indicate the presence of air in this whole region. And you can see them in 1, 2, 3 separate interspaces. So this can be referred to as a ring down artifact or sometimes as a reverberation artifact. And either way, you would see these equally spaced lines reverberating from the interface of the lung wall. And this really will indicate the absence of pathology or of any sort of consolidated patterns. As I mentioned, the pleura you would see up in this echogenic region, and you would want to look for the sliding. The presence of that echogenic line itself is not enough to assume that there's no pneumothorax and that the pleura are intact. Here, because the parietal and the visceral pleura are so thin, you would appreciate even the parietal pleura as an echogenic line. So in order to know that the visceral pleura is also present, you'll see a similarly width line, but you'll see that movement of that visceral pleura. So that's what you're really looking for to ensure that there is no pneumothorax. So where are we going to start looking? We're going to go over a complete protocol here in a moment, but just to start with, some of the best windows that we're going to be using on the assessments of the lung are going to be broken into some different areas. There's going to be the anterior, which is obviously the anterior of the body, the lateral, which would be to the axillary line of the body here, and then the posterior, which would be behind that axillary line back here. So by working our way up, if a patient was in a supine position and we look in the anterior, we would be seeing more the apex of the lung area. As we work down and then towards the side, we're going to be looking more towards those costophrenic angles, and as we come more posteriorly, that's where we're going to be appreciating the diaphragm interface with the lung. If that patient is supine, it's from this region that we'll also see the most dependent area, so that would be the most sensitive area looking for our pleural effusions or hemiperitoneum, or excuse me, hemothorax, excuse me. So we have the anterior, the lateral, and the posterior. We are going to also be assessing the lobes at the following levels: the upper lobes, the middle lobe on the right, or the lingua on the left, and then the lower lobes posteriorly and inferiorly. So we would work our way from anterior to posterior as we move inferiorly throughout the thorax. When we're selecting transducers, it's going to depend on what you're hoping to see. If you're looking for lung consolidation, pleural effusion, anything that could be at a particular depth in the lung, you're going to want to go with a lower frequency curvilinear sector or vector. And remember, our curvilinear is just what it says it is. It's a linear probe arranged on a curve. Sector and vector are going to have smaller footprints. A sector will diverge in an origin like this, whereas a vector will have more of a singular origin and diverge. So these will give you more of a pie-shaped appearance, where the curvilinear is going to give you more of a curved appearance of your scan field. Any of these are usually range at about 3 to 5 megahertz and can provide good access to the depth of the lung. Now, with the curvilinear, it has the widest footprint, so you're probably going to pick up more rib interspaces in this probe, whereas the vector or sector, those you might be able to fit right in between the ribs and only see a little component, the lateral component of each rib, and then possibly a better visualization of the interspace. So you can play with your different probes, see what you like, and just know that you need to keep an adequate depth with these, because the purpose of these probes is to look deep into the chest, evaluating for those lung pathologies. Now, if you're just looking at the pleura, or you can't see the pleura well when we're looking at the rest of the lung anatomy, then you'd want to switch to a higher frequency linear probe. So these can range from 9 to 15. Any of those would probably be acceptable, and these would have that linear face, and you would get multiple rib interspaces using these wider footprint linear probes. Now, the purpose of this is because it's going to give us really good resolution at that pleural interface, and so you'd want to make sure that your focus, if you have one available on your system, is set at that pleural interface, that your depth is really no more than maybe 7 centimeters, obviously depending on your patient's subcutaneous tissue thickness, but you want to set the depth relatively low. You're going to set your focus at that pleural line, because this is what you're really assessing with this. And again, you would see this would be the parietal pleura. You should have another level of the visceral pleura. That visceral pleura is going to be so thin, you're not going to be able to determine which one is which. The only indicator you have, again, is that movement of the visceral pleura. So you have to see that movement to know that that lung is fully expanded. Okay, the ultrasound units that we're going to talk about briefly, you can have any wide array of ultrasound units today, and lots of them can range from the hundreds of thousands of dollars to maybe just $2,000 or $3,000. And obviously, some of that price point is going to determine the quality of the machine that you get. What we were really looking for these exams is that we want a system that doesn't necessarily have to have all the bells and whistles, but needs to have adequate tissue penetration and a good enough spatial resolution that we're able to see what we need to see to get those accurate diagnoses. So an ultrasound unit can range from, a full-size unit that you're going to find in an imaging center or an imaging suite, and those might be out of price point for what you're looking for to do bedside ultrasound. So they're very robust, they're good imaging for all structures, and they contain all of the bells and whistles and settings. So you've got your B mode, your M mode, your color mode, your spectral. You're going to have all kinds of harmonics and compound imaging and a number of other things that are going to give you ability to better visualize things. A lot of those are not going to be necessary with lung ultrasound. Now, the other extreme of the options would be the pocket devices. So these are things like the Butterfly, the V-Scan Air, those types of things that you can quickly link to maybe your iPhone or an iPad and image it. They're very portable. You can image your patient easily at the bedside. The problem with these, however, is that they have limited depth and they have significantly less resolution than your general units. They're most commonly used for point-of-care ultrasound cardiac exams. Now, the structures that we're looking for in cardiac exams are typically larger. You're looking for that, the output fraction and the heart as a whole, but you're going to maybe not have the same detail that you need to get a good evaluation of the pleura. So those are some of the limitations of these pocket devices. They also may not contain all of the settings and options. So they may not have M mode, which in lung ultrasound can allow you to evaluate pleura. So that could be something that you would be missing that you might need. Some of them may not allow you to do Doppler ultrasound or spectral ultrasound, which if you were to come across a tumor or something, you might be interested in looking at that on these lung ultrasounds. But that's probably not as common, going to be commonly as missed as much as just having that lack of end mode. Now, in between these two extremes, we're going to have a number of different units that can range from laptop units to lower end ultrasound suite units to just more robust pocket devices. So just if you're shopping for equipment, just make sure you're asking the right questions and that you're having them demonstrate the equipment on anatomy that you really want to see, know what you're looking for, so that you can assess if that equipment's going to do the job for you or not. So now let's say it's finally time to begin the exam. We talked about what we want to see, why we want to see it, and what it should look like. So now it's time to talk about how we're going to obtain these images. So we're going to select our transducer depending on which approach or what you're looking at. If you're looking deep in the lung, you're going to get your curvilinear like you see up here. If you're looking just for the pleural interface, you're going to probably use your linear. Now, all of your ultrasound transducers should have a notch that indicates the cephalic end of your transducer. That means when I'm scanning a patient and let's say they're supine, sorry for my stick figure, I would take this notch and I would make sure that notch, when I place that transducer on my patient's body, that notch is going to be up towards their head. Then when you go to turn to transverse, then when you rotate this, you're always going to rotate the notch towards yourself or toward the operator. So that would be just the basics of holding your transducer. I know you probably took, the physics and instrumentation course where we went over a lot of this, so I will leave it brief at that. The next thing you need to do is make sure that you're selecting the appropriate preset. So most of your devices are going to have different options like abdomen, cardiac, vascular. Make sure that if your device has a lung setting, try to utilize that. If you're not happy with how the images look, you can also switch to maybe an abdominal setting or a cardiac setting and just see if you like it better. So it's more about how well you feel like you're seeing than whether being tied into a particular image exam type on your system. There's some other things that are going to be really interesting and important considerations when you're scanning. One of the things that new technology with ultrasound has come out with is called compound imaging. And compound imaging, again, if you took the physics class, I'm sorry for the redundancy here, but compound imaging occurs when your transducer is obtaining images at angles. So it obtains an image using scan lines moving one direction, the other direction, straight up and down, and who knows how many other directions, and they will compile all of those images and it will help prevent any loss of information. So here's an example where compound imaging is used, and it's gathering information straight down from the side, from the other side, and straight down, and you see posterior to this attenuating mass, it provides really good information. And so it gets rid of a lot of artifacts. Now, if we were to take this compound imaging off and we were just to image with our general traditional imaging where our scan lines go straight down, come hopefully straight back up, and produce an image, what we would find is an image like this. So this is an attenuating object, and because that object attenuates all of the beam in this area, there is no image beyond that area. So that would be an artifact. We know there is actually tissue beyond this area, and so one of the reasons they created this was to get rid of artifacts. Well, now we're scanning the lung knowing the artifact is what we're looking for, and so by removing some of these possibilities that are settings on our system like compound imaging or harmonics, we can actually optimize our imaging of artifacts, which will make our job easier in this particular area of the body. Now, when you get your settings where you want them, or when you get the image that you want, make sure that you take a moment before you really start assessing your exam to make sure you set your appropriate depth, your focus at the right level, and your gain at a level, because it's nothing more frustrating than realizing after fighting an exam for 5 minutes that all you needed was to make it a little bit darker by turning your gain down or something simple. So make sure it's just your habit. You place the transducer on the patient, you adjust your depth, gain, and window, and then move on from there. Now, your patient positioning is going to be variable, I realize, because you're going to be doing this a lot in the, ICU, in the emergency department. A lot of your patients may be supine. If you wanted to do these sitting, that's fine too. There's not so much a rule of thumb that you have to follow, but just realize you also may have to move the patient slightly to get some of the images that we're looking for. So positioning can be variable. Some views must be completed in a particular position. So we know that gravity is going to affect air fluid levels. So obviously it goes towards common sense that if my patient is laying supine like this and they have a big pleural effusion, it is going to settle towards their posterior aspect of the body. We probably do not have the depth scanning from their anterior body to reach that posterior pleural effusion, and so we would need to have the patient positioned in a way that the fluid would settle, and then we would need to take our transducer and access it from a closer window, like you can see here. So, and we know too, as they're supine, air is going to rise and fluid's going to settle. They do find that infiltrates, so if you have if there's a consolidation in the lung or infiltrates in the lung that's providing a displacement of air, we see that sound transmitted more easily, and we actually see an image brought back instead of artifact that we're used to seeing of the lung. Those images are called B mode or B-line patterns, and we find that those B-line patterns are more apparent when the patient is supine than when they're in other positions. Now, because some of these positions, like looking for a pleural effusion from this posterior aspect of the body, would require us to get our hand in between the patient's side and their bed. Sometimes we may need to roll our patient up into a slight LPO or RPO in order to access that, and if you, it can be challenging, especially if your patient's intubated or something, but just get some help in doing that so that you can get the appropriate window and get a good assessment there. Okay, so now the approach. So first thing you're going to want to do, you've got your transducer, you got your patient in position, you know the different windows you're looking at. Now you're going to want to go ahead and start the exam. So you would, you already set your transducer on that patient, you adjusted your gain, depth, and focus. And now you're going to find the intercostal space of interest. So let's say that you wanted to start a protocol in that anterior aspect of the right lung. You would set your transducer down in long. So that would be in long, would be parallel with your transducer parallel to the patient's mid-sagittal plane in that apical area of the anterior lung. And you would look for the rib interfaces, or interspaces, excuse me. So here would be a couple of ribs, and you'd want to scan down through there, and then you're going to want to look for that pleural lining. Now, if you're getting difficulty picking up information from across the whole transducer face, it might be that you don't have enough gel, so always adding a little bit of extra gel or making sure that you have good contact across the whole area is going to be essential. Okay. So the transducer is placed perpendicular to the pleural surface, meaning it is straight down on the body. When the desired image is not obtained, let's say that you don't have a transverse view of these ends of the ribs. If you're missing that, it might be a simple twisting of the hand or rocking or tilting of the transducer to get that optimal image that you're looking for. So don't be afraid to take a moment to scan. Usually it's very subtle movements of a sweep, a tilt, a turn, or a rock that will get you right to where you need to be. Now, if you're looking at the pleura, you're going to want your depth set at about 7 centimeters. If you're looking more at the parenchymal tissue, you're going to want to go 13 to 16 centimeters. In looking at this, if you see that the pleura sliding that we talked about a couple times before, if you're indecisive on whether you can see that that visceral pleura sliding, there's another option that you can use called M mode. So when you want to verify that what you're seeing on your 2D B mode image here is really pleura sliding, you can turn on your M mode. And remember, M mode comes up with one long line, and it's going to take motion readings all down that line. So you'd want to make sure that you set the line right between in the middle of that intercostal space, and then you would start your M mode. And if you do have pleura moving, what you'll see is this area representing chest wall, this area representing the parietal peritoneum, or excuse me, pleura, and then you would see this movement of the visceral pleura, excuse me. And so because of that, you would know that yes, there is visceral pleura here, and yes, it does have air in there, and that's why I'm getting this artifact. They call this the seashore or the barcode sign, where this would be the ocean waves, here would be the shore, and then the beach, I guess. Now, same example, we did the same thing here. They saw an echogenic line, thought it might be pleura, but once they put M mode on, they never got that motion from the visceral pleura, and therefore they can make the assumption that probably there is a pneumothorax. All right, so you'll see all different kinds of protocols listed, and they can range from 28 view assessments all the way down to 2 view assessments. And so the protocols that I'm presenting here come out of the that second edition point of care ultrasound book by Sonny, Arntfield, and Corey. And it's well supported with some literature from some different studies that I mentioned here, like the study by Daniel Lichtenstein, The Relevance of Lung Ultrasound in Diagnosis of Acute Respiratory Failure. So if you want to look for more data to support these protocols, you're more than welcome to find them at those wonderful resources. But I was trying to imagine in your position what's going to be most integral. What are your goals when you're doing this? And most people's goals are not to spend a lot of time assessing a patient, getting very similar information to what they would get in a very rapid exam. So I gave you a couple different options here. So one of the options that I think that a lot of physicians would like would be a protocol that includes the right anterior chest, which we talked about that in that image with the transducer placements, and then the right lateral chest. This would be at about the middle lobe layer level, and then the right posterior lateral chest, which is that area where I noted that a lot of the pleural effusions would occur. And at each of those locations, this protocol suggests that you evaluate at least 2 interspaces. So you'd set your transducer down, you'd look at one interspace, and then in the same general area, you would slide your transducer and assess another interspace. Then move to your lateral chest, look at one interspace, slide it down, look at your next interspace, and then you're going to go to the posterior region where you're going to look at an interspace, slide it down, and look at the next. And then you go and you repeat the same thing on the left side. Now, that same author that originally created this protocol and had very good results from it, later came out and said that he'd revised his protocol from that study, and he felt that doing the same images, the right anterior chest, lateral chest, posterior lateral, and then going on to the left the same, would still be sufficient if you only did one interspace in that area. So they removed half of the images, and said that that particular protocol was proving to be pretty much the same efficacy as the previous protocol. So how are we going to do this? So from this study, oh, I'm sorry, I was redundant on my slides here, I apologize. So from this study, you can see this would be my right anterior. You set your transducer down there in long, and that would get you a cross section of those rib spaces, and you could therefore look at those interstitial spaces. Then you're going to move more laterally for the middle lobe, and then you're going to go posterior laterally for that inferior lobe. And you need to make sure when you're in this posterior lateral that that is the one that you're going to have to roll your patient up slightly, angle your transducer upward, and make sure that you're perpendicular to the lung field and that you have diaphragm included in your image with your lung. When you're imaging a single intercostal space survey, like we're talking about here, above and below the lung, it's really imperative for records that you take if your system can handle it, that you take a video clip. Most systems now with our robust computer systems are able to handle a video clip, and we can always look at your system and try and figure out how to make that possible for you so that you can save that, prove that the pleura was there, because that's the only way you're going to be able to provide that documentation other than your charting. Now, the hot spot of these exams is really considered the posterior lateral alveolar pleural syndrome space. So they call this the PLAPS point. Okay, so in this PLAPS point, this is the most inferior aspect of the posterior lung. So this is the part that is going to collect all of that free fluid, hemothorax or pleural effusion fluid that's present if it is present. So it's the most dependent area and the lowest area. So to access this, as I just mentioned, you need to possibly roll your patient away from you a little bit more. This would be your third image that we just talked about. So you'd start anterior, then go laterally, and then end up eventually in this posterior lateral position. So patient rolls up, I'm perpendicular to the patient's lung field, angling up towards the ceiling to make access or to make contact with that lung field. And when you do that, you might actually get something that looks a little bit like this, which would indicate a pleural effusion. So here we kind of can see some lung that can be sort of waving in the wind like a sail here, and then this would be all pleural effusion or hemothorax here surrounding it. And so that is going to be the hot spot of where most things are found. Now, just a couple notes about some of the changes that we see. One of the things that we're always going to be looking for is interstitial syndrome. So that would just mean that there's some sort of consolidation in those lungs, allowing sound to transverse through the lungs, return echoes back. Now, we know that's not normal. We know that we should be just getting artifact in the lungs. So when we start to see these B lines, this is concerning, and it's an indicator of interstitial syndrome. So interstitial syndrome is classified when you find bilateral multiple B lines identifying, representing consolidations. Now you have to have at least 2 to 3 of these per intercostal space to prove that it's not artifactual. Every once in a while you'll have a relatively normal lung that has some of the septations can be a little bit widened, and it might produce a B mode, a B line. And so they want to make sure that we're seeing multiple B lines to make that diagnosis. Now, when we look for interstitial syndrome, it has a 97% sensitivity and 95% specificity for cardiogenic pulmonary edema when evaluating according to the current protocols and findings. If the examination is inconclusive and you're not positive whether you think you're seeing B lines or not, then you can also do a 4-zone per hemithorax protocol, where you would do anterior and lateral zones and 2 interspaces per zone. So you kind of do away with that posterior lateral. You're going to be looking more anterior 1 zone, anterior 2 zones, and then lateral 1 zone, lateral 2 zone, making sure that you include the diaphragm on that last image. Scanning, the more regions that you scan, the more likely you are, or the more sensitive you are to picking something up. So when you change from about an 87% sensitivity with 4 zones evaluated, if you go up to 10 zones, it's almost 100% sensitivity. So that just means that you're going to find smaller things because you're looking in smaller spaces, or more subtle findings when you're looking more frequently. To identify this as a positive interstitial syndrome finding, 2 or more positive interspaces bilaterally, meaning that I have this interspace has at least 3 B lines visualized. I moved to another interspace on the same size and found at least 3 more B lines, and then I went to, say, the left side and I found the same findings over there. So that 2 or more positive interspaces bilaterally indicates a positive finding. Positive interstitial syndrome findings can be evaluated with what they call a 28-zone method. And the guidelines for that method are you would do 28 zones, and if you had more than 15 lines of B mode lines in that 28 zones, it tends to be an excellent predictor of people with cardiogenic pulmonary edema getting out of the hospital. It's a predictor that they will be readmitted. So that's another way you can use this for maybe non-emergent exams. So in summary, lung ultrasound is a very useful tool in identifying infiltrates, effusions, pneumothoraxes, and other pathologies. They're based off, the lung findings are based off of the artifacts noted in the image, and those are our A lines and our B lines. There are also appropriate equipment, protocols, and techniques must be utilized to enhance the sensitivity of ultrasound. And the current most practical recommendations for protocols include a 3-zone single interspace per hemithorax approach. But we know that adding additional zones for evaluation can increase our sensitivity. So I hope you find this helpful. If we can help you in any way get started on doing some of these exams to start building your comfort, we look forward to doing that. So thanks again for joining us.